Well, welcome back, PA Lydia.
Thank you. Good to be here.
And it's good to see you. We were supposed to have a person with giant breast implants call in today.
Damn.
And she was actually supposed to be here in the studio so you could, like, I don't know, fondle them and stuff and just see.
Does she live close?
She does, yeah.
Scientific purposes.
And she also had a story to tell. I don't know if I think she got cold feet. What happened, which is totally
I didn't have
fine.
to touch them.
Yeah, no, I know, and she didn't have to even be here. We could have done it by phone, but she may have just decided this wasn't a good thing for her. So,
Well, that's fine.
and it is totally fine. And so I'll just talk about it. She had breasts that she was not satisfied with, and said, if I'm going to get boobs, I'm going to, by God, get boobs. And so she went to this guy and got some really, a full whatever. I don't even know what her cup
Full
size
rack.
is. Yeah, she got the real deal. And about 2 years later, she came down with this rheumatologic disorder. And so we talked about it, on the air. There's a very rare thing called autoimmune syndrome induced by adjuvants, which is not well recognized, nor even there are people who feel that it doesn't even exist, that this had happened to. What happens with some of these folks is they will get a thing called undifferentiated autoimmune disorder. Now, do you ever deal with that, Dr. Scott, at all?
Yes.
So you want to talk about it a little bit, about what happens when this occurs?
We see it probably a lot more than a lot of others, just because it's being undifferentiated. There's not a specific. There's nothing specific to treat. Which is in the Western world, you guys do great things when there's something very specific. If there's an infection or a broken bone or a surgical procedure.
Yep.
And that's why Western medicine's so superior in that aspect. But
in that aspect, but we got to have a damn diagnosis.
But when you don't have a diagnosis or so vague, which we'll see these autoimmune disorders that are very vague and nonspecific. The fibromyalgias, et cetera. So, but what you're talking about, these type of things, for whatever people get these adjuvants, they're and their body creates this robust immune response to it, so they get inflammation all over. A lot of time it's associated with myalgia, so muscle pains, arthritic changes, arthritic pains, chronic fatigue syndromes, et cetera. So we'll actually do acupuncture, craniosacral manipulations on them. We use a lot of astragalus for them.
What a surprise!
It's the greatest herbal medicine ever. But the truth is, we do use it quite a bit for brain fog.
Yeah. So they'll say, these people have this sort of features of connective tissue disease, but they don't fulfill the diagnostic criteria for any specific one.
Yeah.
And they'll have some abnormal labs and stuff now. So this particular person, whether hers is related to the breast implants or not, is impossible to say.
No.
It really is impossible to say. And again, this is a very loosely associated problem that a lot of people in the business don't agree that even exists.
Yeah. Do you think it's possible that she may have had a couple of that in addition to maybe a reaction to maybe a flu shot or maybe a sinus infection or something? And I'm not saying I'm not saying any of those things cause it specifically, but maybe sometimes it's a cascade of insults that the body just didn't tolerate well and blew up.
It could
this
be that,
inflammatory response.
or when it could just be the shit just happens sometimes.
Yeah.
And when it does, you're always going to look for what caused
the
it.
low-hanging fruit.
We see this with, for example, with vaccines and certain conditions that children have and stuff. That really they've done the studies and there's not an association, but you're always going to look for that thing. And the most extreme example I can give, or the most clear example, is the flu shot example, which we've talked about multiple times on the show, but not everybody remembers or listens, fanatically to every single show. Sean Pedrick can recite this, I'm sure. But,
Yay,
but
for Sean. Yeah, for Sean.
Other than Sean, Yeah, and it's the person who gets exposed to influenza on Friday. And so they're going to develop influenza on Wednesday, but they get their flu shot on Tuesday. Okay? So they were going to get it. The virus is in their system, but they feel fine. They haven't started to have symptoms yet. But it's going to happen on Wednesday. They get their flu shot on Tuesday. On Wednesday, they get influenza. You will never be able to convince that person they didn't get influenza from the flu shot, even though it's impossible. So, yeah. And when someone has breast implants or anything like that, and then some rheumatologic thing comes down the pike, it could be years later, you're always going to wonder or try to blame it on that thing because it's the one sort of different thing that happened to them. So it may not have anything to do with it. But I just wanted to see you grabbing her boobs here in the studio.
Yeah,
You can grab.
I've never
Really all
felt
he
fake
wanted.
boobs before.
You can go
Right?
ahead and grab
Something
Tacey's
you need,
boobs if you
because
want to.
apparently they give you like breast implants to like play with before you get them, or maybe wear.
Really?
Right?
Oh, you can wear them?
Yeah, well, pop them in a bra, like walk around, but it's not the
Walk
same.
around and go, "Hey,
you don't know
look at
how
me."
it's going to be like once it's under your pectoralis.
That's
muscle,
right. That's right.
Right?
Yeah.
So
Yeah.
anyway, or above it if you go above.
Well, in 2 weeks, because this part of the bit failed, we will have an adult film person on here who has, I was trying to, Lady Diagnosis has sort of normal sized implants, and then this other person had bigger implants, and this next person will have extreme implants. And then we had somebody calling in that has breast implants. And I think, I can't remember the story. Either she works for plastic surgery or she had plastic surgery. And she emailed me basically saying, well, everything Lady Diagnosis said was wrong, which I don't know. So I don't think that's exactly right. But she took issue with some of the things that she had to say about it.
Okay.
If there was anything, maybe it was some of the negative stuff that she
Well,
said.
what specifically did she say?
Well, I'm going to have her in the very last thing.
Oh,
just to
okay.
do, she's would be somebody that would be sort of a modifying influence on all of this,
Okay.
and I think a positive influence, and we'll have her on.
Cool.
So
Thank
yeah,
you for reaching out.
yeah. Well, I mean, if I can do a long, running bit about boobs on this show,
Oh,
I
sorry,
will do it.
all in.
Casey.
He's all in.
That's kind of a
Apparently,
no-brainer.
there's a culture there, right? Some guys are all about the natural small boobs, and others are like, you better do it while you can.
Well.
Seal your deal for getting a man.
Yeah. Oh well, I don't know. I don't
That's
think
the advice I got recently
what, from a guy.
from a male friend.
Well, that's, of course. What are they going to
just
say?
better
Just don't
do
listen to
it.
that.
Do it in your prime, because if you're 60 and you get a boob job,
It's still
you're out of
awesome.
your prime.
No, that's still awesome. I think that's just fine. Now, yeah, some people like small natural breasts. Some people like large natural breasts, though, too.
Correct.
So there's a whole gamut. There's somebody for everybody.
Yeah, it's just finding that. So
Yeah.
increasing your probability of finding someone
but
that will
you're-
want you.
I want to make sure that let's talk about this for a second. You don't want some guy that wouldn't be interested in you if you didn't have implants, though, right? You wouldn't want some guy that would,
absolutely would not.
right, right. So you're doing this for you,
Yeah.
not for
Things
them.
just change after you have a baby and you breastfeed.
Yeah. If you just,
Absolutely.
Yeah. Not that I ever had much, but
yeah. So if you're doing it for yourself, then that's the right reason.
yes, it's
So
not for a potential mate
Then we will proceed. Okay. All right. Good deal.
or matron. I'm just kidding.
Just not for anybody.
Just not for everybody. That's right.
All right. Dr. Scott, you got anything for us?
No.
No?
Oh.
What? I sent you like 20 things over the break. Oh, by the way, speaking of the break, the WATP Weird Medicine crossover episode on SiriusXM was quite successful. And got a lot of really good feedback for the people that listen on SiriusXM. It didn't come out on the podcast. I'm going to talk to them, see if they'll let us, put it on our Patreon and then maybe slide it over to the podcast side later. And but it was Carl did an amazing job, And if you want to hear more of what he's doing over there, go to whoarethees.com, I think. Whoarethees.com. Yeah, that's right. Or just search on your podcast app, Who Are These Podcasts? And it's a roast show. He does Jocktober. Basically, it's just Jocktober. He freely admits he stole the idea from Sam Roberts in Jocktober. He was a big Opie and Anthony fan. He loved Jocktober, but he does it with podcasts. Except during October, then they do it, the regular Jocktober, they do it about radio shows.
I'm so confused.
And it's
We're
so
all
much fun.
confused.
We're all very confused.
Yeah, well, you guys are, but you guys don't know what Jocktober is. So it's
I'm
fun.
imagining
I
things.
do, and I'm
I have
still
images
confused.
in my head.
Yeah, so they make
was thinking
fun of
like-
Men.
They make.
Mainly.
yeah, like in their jockey.
Jock
Oh, I
straps.
see. No,
Straps,
no.
yeah.
Okay,
Athletes.
so radio jocks, right?
Oh,
So
that's a
Jocktober,
thing?
yeah. So like shock jocks or whatever, and radio jocks. So they would make fun of other radio shows. And back in the day, they would. These sons of bitches. It was so great. They had the Opie and Anthony army, and they would target some radio show that was just, they were doing a bad job, and so it was funny. And they would have different phases of what was going on with their Facebook page. So first, they would notice something was happening. That was phase 1. And then phase 2, they would shut off comments. And then phase 3, they would take their Facebook page down completely. And it was, the fans of those shows, Tacey and I used to say the fans of Opie and Anthony, Ron and Fez were some of the best parts because they were hilarious.
Yeah.
And they really did funny things.
Mm-hmm.
So that's what that was. And so he took this and did it, there's way more podcasts out there than there are terrestrial radio shows anymore.
Sure.
So he started goofing on podcasts, but then in October he would go back to the regular format and make fun of radio shows.
Okay,
So
cool.
anyway,
Yeah, I gotcha.
so I'm trying to see if Jim and Sam would be interested in having Carl on like once every couple of months, and bring in a radio show to goof on, and then he plays clips and they just do jokes. It's a roast. It's just roast stuff. It's nothing
Right.
nothing serious. But anyway, so we'll see. But I appreciate Carl doing that. He did a great job. But you have a story or two to tell. Did you bring anything today,
I
Pete?
got a little something.
Oh, you do?
I got something to discuss.
Okay.
Yeah.
Yeah.
And I've got one, and actually, a movie Messiah's got a good question when it's time.
Okay.
Too.
Yeah. Sure.
Yeah. So the one I brought today was, pardon me, is an addiction drug that shows promise for lifting long haul COVID
Okay.
and brain
Oh,
fog fatigue.
That's interesting. So which one is it? Naloxone?
I would give you a bill, but I don't have a bill to give you.
Okay.
Give yourself a bill.
Give yourself a bill.
I give it myself one.
Yeah, I was going to say so long haul COVID.
I just guessed that, but it makes sense, and I'll tell you why in a
Yeah, I
second.
was
Go
gonna
ahead.
say that. Yeah, I want to hear why it makes sense to you because it's interesting that it took these guys a while to figure it out. We typically use, because we treat long haul COVID with our fatigue reprieve because it's got, again, I know it's crazy, but there's straggles in it. But the fatigue reprieve actually works extremely well.
Can you shut up?
But so don't let that cloud your foggy brain.
Okay.
But yeah, so anyway, what the researchers have found out is long haul COVID, which is really tough to again diagnose and treat, as we talked about earlier.
Yeah.
What
it's because it has such a diffuse collection of symptoms that
non-specific, diffuse symptoms.
some of those could be
any damn thing.
PTSD from COVID as well. You just don't know. But anyway, go ahead.
Well, and we're still so young or so new in the game that
Yeah.
we don't really know what it's long term or long haul COVID is going to be. Anyway, you're all right. It's naloxone. The drug that's been treated or used to treat drug overdoses.
Right.
For years and years and years, I
Right.
guess. And but what they're showing is it has been shown some benefits as far as cognitive deficits, overwhelming fatigues, and some chronic pain syndromes.
Interesting.
Which is really
What dose are they
incredible.
using? Do they say?
Well, I was looking down through here, Dr. Steve. It didn't say, but no. I'm sorry. At 50 milligrams.
Okay.
Which is a low dose.
That's the dose that they use for addiction,
Okay.
and
50 milligrams.
it helps to block. Okay, so naloxone is a thing called a mu opioid receptor blocker. Now, that's just off the top of my head because I did not know that's what they were using,
Yep.
but it makes sense to me.
Yeah.
But naloxone does some interesting things. When you give someone low-dose naloxone, and now we'll use 4.5 milligrams, very low-dose naloxone, for things like fibromyalgia. So if you know someone that has fibromyalgia and they've tried everything else, they've tried the Lyrica and the Neurontin and all that, gabapentin and all that stuff, and nothing's worked as long as they're not already on opioids. You know, if somebody just didn't put them on Percocet or something, you could give those people low-dose naloxone. It's 4.5 milligrams. It has to be compounded. Nobody sells it. But you go to a compounding pharmacy, and what the theory behind this is that when it blocks the mu opioid receptors, these are the receptors that morphine and oxycodone and hydromorphone and all those drugs will bind to that cause their effects. What are the effects? Sleepiness, decreased bowel function, decreased sensation of pain, that kind of stuff.
Perception,
At high enough doses, decreased respiratory drive. I mean, they got lots of different effects. And they affect organ systems all over the place. But the one we're interested in is the central nervous system perception of pain. And when you give someone a low dose of this in the absence of an opioid, it will bind to those opioid receptors in the central nervous system. And you know what can't bind now is what we call endogenous opioids or endorphins. So the endorphins for that brief time can't do their thing because they're being blocked by this low dose naloxone. But it's such a low dose that it's very transient. But in the meantime, these endorphins are building up, and the body's going, "Hey, I got to make more of this stuff." And then when it washes out, these things will flood the receptors, and they really work a little differently than opioids do. They work on the same as messengers to the same receptors, but they work a little differently. And what that does is cause a decrease in overall pain in people with fibromyalgia. So it's off topic, but I wanted to get that out there because I know there's
makes sense,
probably way more people out there with fibromyalgia listening to this show, or they know somebody that is, than people who have long COVID. And if you know somebody, email me and I'll send you the paper so they can take it into their provider and the provider can educate themselves about it.
Wow.
Okay.
That's a good idea.
But anyway, matter of fact, I authored a paper on it, but don't Google that.
So is that something that I could like roll out in my own clinical practice?
Of
Because
course.
right now I do like Effexor and Pray.
Yes.
You know, or
yeah,
Cymbalta
absolutely. You
and
can. No, you can
Pray.
do it right now.
Yeah.
It's not a controlled substance.
Right. And I could do that if it was, but yeah.
But you could anyway. That's right. But I mean, it's harder to get a controlled substance compounded, but that that can be done as well. We do ketamine suppositories for people with rectal pain. Have rectal cancer and stuff all the time. But you can do that tomorrow, and I'll get you the papers and
That'd
all
be
that stuff
great.
so you can back yourself up. I have smart phrases.
It's such a frustrating syndrome to treat.
Yeah. No, it is. It's really frustrating for the patient, and it's frustrating for the provider too, because you want your patients to get better.
Yeah, you want them to come back and say they feel better, and it's very difficult.
I've
to
had
establish
really
that.
good luck with that, and even other chronic pain syndromes, as long as they're not already on opioids. Because if they are, now the opioid and the naloxone will just fight, and it doesn't do any good.
So can I ask you a question about that? Wouldn't you discontinue the opiates?
But they got to be off of them for a while.
Okay, gotcha.
Yeah.
Because to me that would make the most sense.
Yeah, if you could get somebody to
It'd be some buy-in.
it'd be some buy-in. If they're on high dose, they'd have to taper over. I mean, I've tapered people over 3 months before. I mean, I go easy. I got a cancer patient that got cranked up on opioids because of chronic cancer pain, and then they get treated and their pain goes away. Now you've got to get them off. I've done 3-month tapers before.
Right on.
If you got somebody that's on 20 milligrams twice a day, it can take a month to humanely get them off their drug. And so that's a big commitment for somebody if they, if you don't know if this stuff's going to work,
Yeah.
So, but even then, there's probably some benefit to it because if they did have to go back on the opioid, they can go back on a much lower dose.
Sure.
Anyway, so 50 milligrams of naloxone is what they're using for post-COVID syndrome. And are they? So you said it's mostly for the brain fog?
Yeah, primarily brain fog, but they are showing it helps them with the pain and with the fatigue.
Yeah. So what if the brain fog is caused by an overexpression of endorphins in the brain because they act like opioids? Maybe that's where the fog is coming from. And so there's maybe some mechanism that's causing an overexpression. And when you give people this slightly higher dose, but it's 10 times higher than the low dose naltrexone is what we use. They may, it may actually block that and give them some relief from the foggy activity of endogenous or internally created opioid-like molecules. So that might be it. Yeah. And
Interesting.
it's low-dose naltrexone is what we use, but naltrexone and naloxone, very similar molecules. But that's where all the studies have been done for the ultra-low dose stuff. Anyway,
That's
all
good
right.
stuff, Dr. Steve.
Yeah. Very interesting.
Very interesting.
So I'm going to pass that on to our long COVID clinic because I wasn't aware of that study. So if you'll forward that to me, that was a good one, Scott.
Yes.
Give yourself a bell.
Give you a bell for bringing in a good story. Might help somebody.
1-to-1. We got
It's
one
definitely
bill apiece.
going to be changing some of my patients, I think.
Yeah.
Some of my management.
Yeah. What else you got? You got anything else you want to do?
Yeah, well, I've got a
ahead.
real quick question from Moving Messiah, which is actually right on point. He was asking, as far as breast augmentation, if someone gets a breast implant, can they still have a mammogram?
Oh,
Yes.
Yeah.
Oh, yeah, absolutely. Absolutely, they can.
Yeah.
And I've seen tons of them. It can make some things more difficult, which is, again, I think, well, I mean, it's not in the breast tissue. It's either on top of it or below the pectoral muscle. So if it's below the pectoral muscle particularly, all the breast tissue is separate from it. It's above it, yeah.
Yeah, front center.
Yeah.
Good question.
Yeah, we see that all the time.
Yeah, good
And
question.
they'll say, this person has XCC breast augmentation as part of the reading of the mammogram.
Okay.
Now, I do wonder, I know if you squish breast implants, if you have them in your hand, not inside somebody's body, but I mean, if if they just hand you the actual implants, you can squish them pretty tightly. And because, Tacey, you've probably had more mammograms here than anybody in the room. When they do that, they really compress the crap out
They
of
really
your
do.
breast tissue, right?
Pancake.
Yeah, so
Wow.
I was always concerned about that. But when you feel the breast implant, it can take it.
Yeah, it doesn't hurt. And
How
I mean,
can that not hurt?
It just doesn't. I've heard some people say that it does, but
Yeah.
it doesn't hurt me.
Yeah,
And I have sensation and everything, and it doesn't.
yeah. I know that there's not a lot of sensory fibers in breast tissue itself, because back in the day when I was doing primary care, I would do needle aspirations of breast cysts, and you would do it without anesthesia, because if you did anesthesia, it hurt longer
Than actually doing
than just doing it. Yeah. And once
Now-
the needle was in there, they had no pain whatsoever.
It's a very uncomfortable position. You know,
I haven't.
Okay,
done it.
tell us
never-
about the
never had
position,
it.
because I don't even know.
I don't even know how to describe it. You have to contort and stick your
So you put your arm over your
boob
head.
in this, and you hold on to this one thing, and you hold on to this other thing.
Over your
It
head.
looks like you hug a tree.
Yeah, it's like hugging a
kind of
tree.
like that, but then they have you in different positions, so
What?
it's crazy.
While they're squishing your boob, or they're unsquishing?
and they help you get into the position because it's not easy to get it all. I mean, I
Does
guess
the machine, and this is going to sound weird, but does, like in dental imaging, it kind of rotates around your face. Does this move too?
it goes around,
Okay.
if I remember right.
Not with your breast in between two plates, though. They don't start
Does it
moving it
rotate a little
around.
bit?
God, that would be horrible.
Squeezes it and then
Rotates.
then it goes. If I remember right,
How could you forget that?
Have you ever had a 3D
Hey,
mammogram?
Dr. Steve, road trip.
I've never
Road trip.
had.
I wonder
it
if that's any different The 3D mammography.
They it's supposed to be better, right?
Well, all four
But
of
I
us
don't-
are just throwing out, well, I wonder if, I don't know either.
I just wondered if it was like a different process.
Now,
but then there's breast MRI, of
I was just
course.
going to say that the breast
Yeah.
MRI, you don't have to do any of that, right? And
Right.
but you have to lay in that tube. And MRIs, okay, when I was training in the 80s, a CT scan would take 45 minutes.
Wow.
And they had giant mainframe computers in there. Now you could do it on a laptop, basically. And so when I had my first MRI, 15 years ago or something, it was 45 minutes. I figured, well, hell, that'll get better. It hasn't.
It has
It's
not
still
improved.
45 minutes to do one.
Yeah.
I had a finger, a nodule on my finger, and this orthopedist wanted me to get an MRI of the finger. So I thought I'd just sit in the chair and stick my hand in there. Oh, hell no. I was
You
on
had to
all
be in the
fours.
tube.
In the tube, on all fours. I know, it's hilarious and I was praying to Jesus, if you get me
who
out of
can
here.
do that?
I was
What
in,
percentage of your patients can actually do that?
and not move. I was
Yeah.
in so much pain just from having all my weight on my elbows and my knees.
Yeah.
And with my hand in front of me. And I don't know why you have to do it that way. And I was praying to the good Lord above, if you can get me out of this thing,
And
Lord,
the-
I'll never,
So when are they
I'll never curse
recommending?
again. It was awful.
When are they recommending mammograms now? It's 40 and above. Is that?
Oh, now see, you had to ask me that. I want to get
That's
this
why
right.
you haven't had one. I was like, why hadn't you had one?
Mm-hmm.
But I've been doing them for so long, I forgot that not everybody had one every year.
Well, let's see here. Women age 45 to 54 should get a mammogram every year.
Well, you're not even
I
close,
think they
Lydia.
changed that.
You got like
Not-
20 years before you
I
get
don't
there.
know.
Okay, this is from cancer.org, which is the
I thought it was
American Cancer Society.
used to be 40, right?
Sorry. Okay.
Super glue.
And then women 55 and older should switch to mammograms every 2 years, or they can continue yearly screening. They're just saying they should. And screening should continue as long as a woman is in good health and is expected to live 10
Yes.
years or longer.
Thank you.
Okay. And all women should be familiar with the known benefits, limitations, potential harms linked to breast cancer screening. All right. And as always, women should know how their breasts normally look and feel and report any breast changes to a healthcare provider right away. Okie doke. Now, you mentioned MRI. They actually bring that up. They say because of their family history or a genetic tendency or other factors, some women should be screened with MRIs along with mammograms. The women that fall into this category are very small. I would assume it would be BRCA positive.
Yeah, BRCA, check 2, PALB 2.
You want to talk about what that is?
Yeah, so that's where you have inherited a mutation from either parent in a gene that should normally protect you from cancer. So normally if a cell starts going rogue through DNA division, your body would recognize that perhaps through one of these genes like BRCA1 or 2, PALB2 or CHEK2 and turn that process off. So stop that cell line. If you have a mutation that's causing a defect in that gene, then you will not turn that cell line off, and you would be more likely to develop cancer.
Okay.
So,
And knowing that you're more likely to have cancer means that you're probably less likely to die from it because you'll catch it earlier. You'll do something proactively to take care of it.
yeah, so you start screening earlier, so 10 years earlier than the youngest first degree relative. And then the guidelines recommend annual MRI and annual mammogram. So we split those every 6 months. You're getting some type of imaging.
Okay.
If you don't do prophylactic mastectomy.
Yeah, which means
Cutting your breast tissue off.
right. I had a time before just cutting it off with the pass, and then then those women, some of them will have reconstruction, some won't. Some of them just say to hell with it. I just don't want to mess with breast cancer. I don't, I'm going to take care of this before it happens.
Yep. Yeah, and a lot of women will choose. They'll have their kids first, and then go toward it.
Do you think that in the future we could have some sort of CRISPR technology where we could just fix the defect that causes the BRCA, mutation?
I don't know, because your cell lines are already differentiated, right? So doing it in the backwards setting would be very difficult.
Yeah.
But
You do turn over, though. I mean, you've heard of the ship of Theseus, right? Where, you keep replacing boards in the ship, and down the 100 years from now, there's not a single board that was there, but people have lived on that ship consistently the whole time.
I would imagine
And our bodies are kind of like that. The nerve cells don't turn over like that, but other cells do. I just wonder.
I would certainly, I would expect it to significantly reduce the risk of developing cancer if
think
you were
so.
able to do that.
Again, this is the speculation show.
you
We're
would
speculating
think.
about lots
Yeah,
of
and
stuff. We don't know what
What
the hell
you
we're
can
talking
do,
about.
what you can do, and why it's important to get tested early, is that you can go to fertility specialists if you know that you have a mutation, and they can select for eggs or sperm that do not have the mutation. So
Really?
yeah, so I do our genetic counseling.
I didn't know
for
that.
the area. I'm not a genetic counselor, right? I work in oncology, but I see patients who say they just got diagnosed with breast cancer, or their mom has breast cancer, something like that. So the benefit of early testing is if you're if you know that you have one of these mutations that will convey an increased risk of cancer, you can go to a fertility specialist and have the egg or sperm selected, right? Because you only have a 50-50 chance of passing on that mutation to your
Right.
offspring,
How
right?
in the hell do
So
they
then you do
that?
your in vitro fertilization, and they test the genetics
with in
of
vitro.
the
Oh, I
eggs
see.
and sperm, and they select and match only those
Okay.
without the mutation.
I was like you. I'm like, how are they going to do that once the
right,
seed has
right.
been planted?
Right.
Yeah.
Once,
So then they plant the seed outside of the body.
right on.
And
Yeah,
then,
okay, that makes sense.
Wow.
yeah.
Wow.
Interesting.
Okay. Well, thank you. I'll give you a bell.
Give yourself a bill.
Daisy, you're the only one
I
that
don't
doesn't have a
have
bell.
one.
Bill. Give her one just
No,
because
you don't
she's
just
awesome.
give out
Oh,
bells.
but she's awesome. She gets one.
I agree with you, Scott.
Number one thing, don't take advice from some asshole on the radio.
All right, you ready? We've got we have one that's right up your alley, Scott, and then this one. Let's try this one. Let's see. Oh no, don't! Come on. There we go.
Hey, Dr. Steve, I got a question for you, or maybe that wizard Dr. Scott that sits next to you. I use a CPAP machine, and I fill it with water. Or I tend not to fill it with water because it's annoying, but I probably should. But so, is there something that I could put in the water to make it beneficial to my health? Maybe right now, like when I got a cold, some menthol or something like that. I don't know, maybe some crazy powders from some Asian places. Let me know. Thank you.
Astragalus.
Watch it now. You're starting to sound like Dr. Steve.
So yeah, what do you think about that?
Well, my first thing is I'm not going to tell anybody to put anything in there. In
There you
CPAP
go.
Or anything. No, heck no.
No.
The
No,
manufacturers would say no.
No,
but
they would frown upon it. Yeah, but now there are natural occurring or natural antimicrobial agents like oregano oil, peppermint oil, things of that nature. Maybe something you could use, but not. I'm not going to tell anybody to put anything in a CPAP machine. Follow the directions that are on the box or that your providers have given you, and stick with that. But now he could always use a fancy nasal spray that maybe has
There you go.
peppermint oil.
That's what I was
and
going to
like
say is do
Yeah.
something
your
before
Simply
time.
Herbals nasal sprays, which are
I am
fabulous.
at cpap.com, that famous medical journal, and it has an article, How to Safely Put Essential Oils in Your CPAP for Aromatherapy.
Oh, well, okay.
And then,
But this is not coming from
no,
me.
hang on. And then you come down here and it says, putting essential oils in your CPAP machine is not safe.
There you go, there you
So that, what a clickbait title.
Mm-hmm.
It says it does not matter if you put them in the machine itself, in the hose or the mask, or in the filter, or in the CPAP humidifier. So it says here, according to Randy Horowitz from the Arizona Center for Integrative Medicine, if you add essential oils to a CPAP machine, the device could propel droplets of the oil deep into your lungs. In an interview with Dr. Andrew Weil, we know who Andrew Weil is, Dr. Horowitz warns that even a small amount might cause lung irritation. So we're going to say no to that one. Now, but if you want to get some nasal spray that has peppermint oil in it and without, it's FDA approved, right? To the extent that it can be.
That's correct. Yeah.
Then that's that's between you and Dr. Scott.
Yep.
All right.
Yeah, but I wouldn't put anything in the
No.
sleeping.
Nope.
No. Sorry, dude.
Yep. Sorry, man. It's a cool idea,
Yeah.
but I wouldn't do it. I'm actually, Martin Hoke from Navage will tell you that unless it comes in one of his salt pods, don't put anything in the Navage either. The Navage device, which if you go on our YouTube channel, you could see NP Mel B doing the Navage. And it's funny because she hates things going in her nose, so she was quite humorous about it. But he has salt pods that have menthol in them. And that actually feels really good when you do that. And you get that sort of menthol, that always,
feeling.
tingly.
Ooh, I like it.
I like it too. So anyway, all right. Here, this is one for you.
Hey, Dr. Steve. This is Terry, otherwise known as the Bootmaster.
Hey, okay. Hey, Terry.
You've been extremely helpful to me in a number of ways over the past years, and I need your help now.
Okay.
I have 9 discs that they want to fuse, cervical and thoracic.
Okay.
I can't do that in my own head. 2 reasons. One is I have an issue with anesthesia not coming out of it. Number 2 is I don't need to be more robot than human.
Yep.
So,
well, you wouldn't be, but I
the
agree.
problem I have is significant pain. The pain comes usually at the base of my skull, can be either side, usually goes down my neck and to my upper back.
Okay.
It can be extremely debilitating, and other days I can be human.
Right.
One of the things that happens, and one of the reasons why I'm calling, is there's something that's unusual that happens, and what that is if I sit or stand and look up 15 degrees, 20 degrees from straight plane, if I look up a little bit, and I do it for more than 30 seconds or so, putting in a light bulb, talking to somebody who's standing while I'm sitting, I get this bolt of pain that comes out of the side.
Yeah. Doc, it hurts when I do this. Yeah. Well, don't do that.
Don't do it, yeah. Don't do it.
So before this call's only about halfway through, but first thing, don't put in light bulbs like that anymore. No. Go to an occupational therapist, and or you could just do this yourself and go get one of those robot arms and do that stuff that way.
Yeah.
And you can even put a little mirror on it so that you're looking down instead of looking up when you do that even. But there are assistive devices that you can use because you're not going to be able to do those things until these discs resolve, if they ever do. So.
Out of my head, the base of my skull, and goes down into the top of my shoulder. And it is the most horrific pain I've ever experienced in my life. This can happen once a day. It can happen, God knows, sometimes.
Just when you do that one thing. So if you're sitting in a chair and someone wants to talk to you, stand up or make them sit. Hey, have a seat. You don't have to make a big thing out of it.
It's all
well, if I look up, I'm going to have, you just either stand up or just make it a natural thing.
I'm lucky enough to have it be weeks before it happens again.
Yeah.
Sometimes, as it is today, which was it's horrible today.
By the way, this is why they want to do a fusion on him, so that he can't do that anymore.
I had a.
There's other things that are done when you do a fusion, but we'll talk about it.
My ears will ring.
Yeah.
They've been ringing now for over an hour. The pain has somewhat subsided, which is usually what happens 15, 20, 30 seconds later.
Yeah, Terry, it's horrible, man. I understand the reticence in having surgery. I was on Levy Land recently with Bob Levy and his crew, and I talked about how I basically just said no to surgery until my pain went away. I'm one of the lucky ones. Discs will, over time, desiccate and shrink and, dry out and shrink back to where they were supposed to be when they bloop out like that, because now they don't have a good blood supply. And maybe we should talk about. You want to talk about why a slip disc is a problem? Because I sort of skipped ahead.
Well, yeah, and just a couple things, just taking it from the very top.
We'll talk about the spine and the anatomy of the spine.
Well, the biggest concern that I hear him saying when they start talking multi-level fusions,
Yeah.
The first thing you think is multiple disc failures, but what a lot of people don't realize is many instances it's because of a stenosis. So there's a narrowing of that canal, right? And at first I thought that's what he was describing, but then I kind of changed my tune just a teeny bit, because when he started talking about it being positional,
right,
and then I started thinking like it's probably a disc compression, maybe a spondylolisthesis, which is a shifting of that vertebra, which is another for stability. That's why they'll do the fusions a lot. So a couple things in Dr. Steve, perfect. There are a lot of adaptive devices in certainly physical therapy, occupational therapy, to help you to reset, posturally, make sure that you're doing things appropriately, are really good suggestions. Depending on which levels are affected, epidurals, steroid injections can be beneficial, and you've had those, certainly. Let's
talk about that then. I mean, that's a big.
That's a lot. That's a big subject we're talking about right here with this poor guy.
Yeah. What I was kind of wanting to get to was the anatomy. Just a basic thing is just think of your spine as being a bunch of balsa wood blocks stacked on top of each other with sort of gummy bear discs in between them.
Right.
And when you stand for 67 years upright and you're putting all that pressure on those balsa wood blocks because of gravity, sometimes the gummy bear discs will just bloop out, and when they do, they bloop out in a way
usually the wrong way,
right? That impinges on nerve roots,
right.
That coming out of the spinal column, and so the spinal column houses this nervous. This network of nerves, but also gives you stability so you can stand up straight. And so, as Dr. Scott said, well, go ahead.
Well, I was going to say, and the way you're describing is perfect. But the other really super cool thing about the spinal cord is the spinal column. Those balsa wood blocks are in a curve, a natural curve, and there's got to be a natural curve, so that if there's ever any insult, there's a shock absorbing component to it. So, and the other thing is if maybe he has an abnormal curve or lack of a curvature, or something that some other therapies can do other than a fusion. I'm not saying he doesn't need a fusion, but I'm saying there's a whole lot of things that we talked about.
Well, they sometimes will have to go in there and take out some of the bone to give those nerve roots enough space to breathe.
A laminectomy.
And that's right. Yeah. And then when you do that, that makes that vertebrae unstable, and that's why you have to fuse it. Yeah. And if you have to do it on both sides,
if you do it on both sides, right? Yeah.
So they may be thinking about putting rods in his spine. They're called Harrington rods.
Yeah, Harrington,
and or it may be just a cage going all the way down. And I totally get that.
Sure.
But I would do all the things that Dr. Scott said. So let's talk about the things he can do. Yeah. So occupational therapy, physical therapy.
Acupuncture for sure.
Sure. There's absolutely no reason not to do that, as long as you don't go to a nut. Go to someone who, like Dr. Scott, who knows what they're doing, but and knows the limits of cranking your head around when they're sticking these needles in.
Right.
And then and the next thing is epidural steroid injections, because those are needles that are stuck in around the spinal column, not in it, but around it. That's why they're epidural. They're around the dura, and which is the lining of the spinal, the spinal column where the fluid is. And they can put steroids in there, and that will induce anti-inflammatory
shrinkage.
Yeah, and it's and then the discs start going, the shrinkage. It's the shrinkage.
Yes, that's right.
And that's a good thing.
It's a good thing, yeah.
When I had my epidural, I'm telling you, within 12 hours, I could tell the difference. And the next day, I was, instead of crawling up the stairs, Tacey, you remember how bad it got. I was bouncing around doing my thing again. So that's important. And I do everything that you can short of having the surgery. But in the end, if you have signs of nerve damage,
and I was going to say,
foot drop in the lower ones, or your hands are going numb, or you can't grip, or anything like that, that actually becomes a true indication for surgery. You got to have it.
It's I always tell people there's two things to look for: motor loss and sensory loss. If you've got either one, then I get really concerned.
Yeah, then you got to start really thinking about it.
You have to consider surgery before it gets too far down the road.
Yeah.
But if it's positional like this gentleman was saying, it's usually a pretty good sign that we might be able to do something non-surgically.
Yeah.
Or at least minimal surgery.
Right. You should at least try it.
Yeah.
But do whatever your primary
the doctors
team tells
Yeah,
you.
not us. We're just crazy.
We're a
people.
bunch of knuckleheads on the radio, right?
That's right on.
You don't even know if we have a
us crazy people. But we
medical
love
degree
fluid.
or anything, but we like to talk about it.
Yes.
All right. Okay. Here's a good one. Let's see. And we'll go around the table on this one. And actually, that's to kill time because I forgot to Google the answer. You ready?
Hey, I got a strange little question for you.
No.
What bone in the human body is fractured or broken the most, and why? Just one of those weird things you wake up at 3 in the morning and wonder. See about Tasty!
Oh, Lord.
So are we going to guess?
Thank you,
Are
Stacey.
we all going to guess?
Yeah. I do know the answer, and it surprised me, to be honest with you, because what I thought it was going to be was something completely different. So, okay, Scott, what do you think?
Gosh, fifth metacarpal.
That's interesting. Okay, so tell people what that is.
So
and
why?
And why
and
you
why
think?
that's my guess.
Yeah.
So with this, the bone on the outside of your hand, it's the fifth bone in your hand, going to your pinky. A lot of people will break.
It's in the palm,
Yeah, in the
right?
palm of your
It's
hand, yep.
the very edge of the palm. You know the long bone in your hand
yep.
that goes to your pinky.
Yeah,
okay,
it
so
goes
go
from your
ahead.
wrist to your pinky. Yeah, I'm sorry.
And
Yeah, but people, a lot of times when they punch things, will punch incorrectly and wind
Right.
up punching this, and they get a boxer's fracture, a puncher's fracture, and break that bone.
We used to call it the fool's fracture
Yeah.
because only a fool punches that way.
Yeah, right.
Yeah.
Yep.
So, okay, so Tacey,
That's my
what
choice,
do
yeah.
you think it is?
Pinky toe.
Pinky toe?
Ah, perhaps
Good answer, good answer,
undiagnosed,
good answer,
actually.
good
It may
answer.
not actually have factored into this.
That's true. So this
That
would be
is
the
true.
most diagnosed
Because you
one.
can't really do anything with it, right?
So people just don't
tape
go.
it. Yeah.
Yep. Okay, what do you think?
I
Lindsay?
have to withdraw myself because I know the answer.
Oh, you do?
Yeah,
Why do you know?
Of course she
because I
does.
looked it up.
Oh, you looked it up while we were talking?
Yes.
Okay.
I didn't know this was going to be a game.
Okay, well, what would you have said?
I didn't get that far.
Okay, what I would have said was one of the metatarsal bones, which are the long bones of the foot.
Yeah.
And my reasoning for that is, you see stress fractures, all this kind of stuff all the time, is because you put in my case, 170 pounds of weight on those up to 10,000 times a day
They're so
when you're
small.
walking,
Yeah.
And why don't those break all the time? Well, that wasn't the right answer. So, Lydia, what's the answer?
Clavicle.
Yes, that's correct.
Your
No,
collarbone.
it's not.
Give yourself a bill.
And it's because
Collarbone.
kids break their clavicles. They're clumsy and they fall. And my niece Holly broke her clavicle. When I was in primary care, I did some pediatrics, and we were treating clavicular fractures all the time. So once I saw that, it was like, yes, of course.
Yeah.
My doofus nephew, who I love dearly, broke the crap out of his clavicle snowboarding. He hung the front edge, face planted, pow.
Yeah.
That was awful. He had to have surgery for his. He's got plate and screws.
Yeah, and
Oh,
every source I looked at said the same thing. So
Yeah.
it's the most common site for a fracture in children. Clavicle fractures happen to infants during birth as they pass through the birth canal. Clavicle fractures can also happen from falling with your arm outstretched or from a direct hit, which happens most commonly during contact sports. So there
I
you go.
broke mine. I got hit by a car. I was riding a bicycle.
There you go.
Broke my clavicle.
Did you really?
I was like, surely my entire arm is shattered, but it was just a small clavicular fracture.
I ever tell you guys the story of my last delivery that I did? Have I ever told that on here? I think I can tell that. It was 40 years ago. No? Okay. I don't know if I've got time to tell it now.
Oh, boogers.
But yeah, it was terrifying. It was the last delivery for a reason. I was third-year resident. I was almost done anyway, but it was somebody I'd followed for a long time. And got the head out, couldn't get the shoulder out. It's called a shoulder dystocia. And so I said, okay, I don't want to do the main maneuver for getting this kid out, this sort of screw thing. I'm just going to put downward pressure on the kid's head because the shoulder was right there. Can I get it out that way? So I was putting downward pressure on the kid's head. It's just a vagina and a head sticking out. And I hear this crack and the kid comes blooping out, right? So I'm like, oh my God. oh my God, what have I done? And so I hand the baby off because now I've got to attend to the mom, right? And I said, check that baby. And I was sweating bullets. Totally fine. Totally fine. Baby, totally fine. Check the mom. Totally fine. Do you hurt here? Do you hurt there? No. The kid's clavicle, okay. Yep. Moving all four extremities, totally fine. I said, never again. That's it. I am done with this shit. I'm never
Bye.
delivering a baby as
Bye.
long as I live. And I have held up to that promise.
Good job.
Oh, man.
Jeez.
You're just gonna, if you see someone delivering on the side of the road, just pass them by.
Well, I
You don't
will.
have the duty.
I know.
I'm just kidding.
We got to talk about popcorn lung next time because we made a couple of misstatements. Surprise. We talked about something we don't know anything about. And so we'll talk about that next time. Thanks to everyone for listening. Until next time, check your stupid nuts for lumps, and we'll see you. We'll see you next week. Thanks, everybody. All right.
What'd you say wrong about popcorn lung?
It's actually wasn't the popcorn lung wasn't caused by and a matter of fact well I would like to get it on both shows. It was caused by a thing called diacetyl, and it was caused by the flavorings that they put in it.
Oh.
And the reason it's called popcorn lung isn't because it looks like popcorn on the x-ray, even though it does have splotches on it. It's because it was caused by diacetyl is used in artificial popcorn flavoring in like Orville Redenbacher type plants, and people were getting it from there, from breathing it in at work every day. Isn't that interesting?
But it does look like popcorn.
It does look like popcorn to me.
Obliterated.
And then the vitamin E acetate caused e-cigarette product use associated lung injury, which is a completely different disorder. So, yeah, I just want to clear that up. But we'll do that next time. All right. You want to just wrap up the podcast, or do you want to answer? Anybody got anything in the waiting room?
Yeah, Scott's got a great question, and I asked him if he'd rather us do it now or next week. He said it didn't matter.
We can do it now.
Yeah, we'll do it real quick.
Yeah, we can do it. All right.
It's a great question. Yeah.
All right. Ooh, shoot. Okay, hang on. I didn't like that. All right, Dr. Scott, you got any questions from the waiting room, my
The
friend?
waiting room, we do. We have a great question. So Scott's got a question about. He just started an antidepressant for anxiety and depression.
Yep.
And he's had a couple of the initial side effects, which he tolerated really well, and they faded away. He said now he's got a little bit of an erectile dysfunction disorder. He said he has no trouble getting the erection. It's completing the transaction.
Yes.
Which
he has
is the
delayed
issue.
ejaculation.
He has delayed ejaculation. So
It's very common.
holy cow! He says sometimes it takes an hour and a half.
Yeah.
Who got time for that?
Oh,
I
my
ain't got no time
God.
for
Oh,
that.
yeah.
I ain't got no time for that.
Yeah, that's like normal.
Oh my God.
Tacey hates that too. So we've had to make some adjustments over the years, but yeah, that's
In and out.
Yeah, let's get it over with.
Tacey-
Let's get this done.
Because she's married to an old man, and who wants to have an old man
That's
on
not
top
it.
of you?
It's just in and out.
Get it over with. Yeah, I got laundry to do. Come on, hurry up.
So yeah, so there's an interesting solution that might work for him.
Okay.
One of the things you can do, of course, is change antidepressants.
Yes.
That's one thing.
Because
Another thing
SSRIs are
are known to do this.
notorious for it.
So, but then you're on another antidepressant for 8 days. He's already gotten through most of the adverse effects. Got to start all over again. You could add another antidepressant called Wellbutrin or bupropion, which is more works on the dopamine receptor axis and may reverse some of the adverse sexual effects of an SSRI type antidepressant. When we say SSRI, we're talking Prozac, Zoloft, that kind of
He's
stuff.
on Lexapro.
So he's on an SNRI.
Yeah.
So those can still have it,
Yep, same thing.
though
Or
slightly
same thing,
different.
slightly
So
different.
SNRI just stands for serotonin norepinephrine reuptake inhibitor. So they are more like the old classic antidepressants like amitriptyline and nortriptyline, which also elevated levels of serotonin and norepinephrine in the brain, which are just neurotransmitters. They're just chemicals that signal between nerve endings in the brain. So you could do that. But the thing that I find the most interesting is taking a non-drowsy antihistamine 30 minutes before intercourse, or maybe even an hour. So you could take fexofenadine. What's the other one? Loratadine. That is Claritin. That's the one that I saw most of the research on, is taking a Claritin about an hour before. Now, you have to schedule it then. That's the thing. But they try it and, do your own research. But if you think that it's something you want to try, you could try it and then report back to us. I mean, it's over the counter. I don't mind recommending over the counter things to people if they want to just try something. So that's an interesting solution to that we've had some people who've tried it on this show that have gotten good results. And that's way counterintuitive.
Yeah, that doesn't make sense at all. But
yeah.
Well, I'd say give it a shot.
All right? Because I'd rather do that if that works than have to just start all over again.
Yeah, and start a new medication. Yeah. Well, good luck, Scott.
And the other thing, Scott.
Try it out there, buddy.
Stop beating off, too, so that you've got.
Isn't there music for this?
Oh, yeah. Stop beating off.
There we go. Sean was actually looking forward to hearing that.
All right. So, but don't masturbate if you're worried about completing the transaction with your partner, because if you're right on the borderline of being able to complete the transaction, that'll kick you over the cliff and it'll be much harder. So you want to have a full batch, as one of our friends on the internet likes to say. So, all right.
God.
That's so disgusting. Anyway, all right. Anything else for anybody?
Yeah, that's
a good question.
That's a great question. Yeah, these are the ones we can table until next week.
Antidepressants are interesting. We just sort of did biopsies on brains and realized that people with depression had low serotonin levels.
So that's how they came up with it.
So we just dump buckets of serotonin in there and hope that's going to do something. And sometimes they work; they're amazing, and then other times not so much. So we need to get a better, sort of more precise idea of what we're dealing with. But as we've said multiple times, we don't know how consciousness works. So when it breaks, it's really hard to fix it. Just imagine Tacey trying to fix and this no flies on you, Tacey. I'm just trying to think of something that you don't have any experience with. An internal combustion engine. It would be very difficult to do.
Drive it to the dealership.
Right.
Have it towed to the dealership.
Yeah.
That's what. That'd even be better.
So that's how we kind of are with brain. Conscious disorders of consciousness. We don't know what the hell we're doing. Ketamine, very interesting though. And ketamine for depression, particularly major refractory depression that might otherwise go to electroshock therapy or something like that, has been shown to be pretty damn effective. Matter of fact, it's on the market now. But you can get compounded ketamine as well, and you got it. As every state's different, so you got to check it, with your prescriber and see if it's even legal in your state to do that. But we're making some progress. The consciousness is the final frontier. We made some pretty good steps with oncology, which was the final frontier. Yeah. But the nervous system is really going to be the thing where we're going to make the final strides. And